plastics that were the most problems.
Thank you.
Everyone has this, and it's in the analysis.
Thank you. Now we'll move to Ms. Mitchell.
Thank you, Chair. I was just trying to. I was not clear in terms of some of the statements Dr. Pan made with regard to the specific brands of formula for medically fragile infants. Were you suggesting that they aren't currently marketed in alternative containers like these, or based on the chemical balance of the formula, they cannot be? I wasn't sure your point.
Basically, from the information I've gotten from the FDA, they are working on alternatives.
But they don't currently have them.
But they do not currently have them for particular types of formula that they have approved to ensure the stability of the formula, that you don't have bacterial growth and other types of things. So if the witnesses have different information, I'd like to see that as well. But that is what I learned from people at the FDA yesterday.
Thank you. Other questions, comments from committee members? Seeing none, would you like to close, Ms. Butler? I'm sorry, Mr. Williams, did you have a question?
The bill does have some time to take effect, correct?
Yes. It'll be July of 2013.
Thank you. Would you like to close?
Yes. In closing, I wanted to address the enforcement comment made by the opposition. And Assemblymember Ma in 2007 passed AB 1108, which banned phthalates in baby products. And that bill had no enforcement mechanism. We're finding that the independent testing so far is fine, that manufacturers are already doing a very credible job of taking BPA out, and we don't feel that there's a testing mechanism necessary in this bill. And with that, I respectfully ask for an aye vote.
Thank you. So we have a motion and a second. This is due pass as amended. I'd ask the clerk to call the roll.
Monning?
Aye.
Monning, aye. Logue? Amiano? Aye. Amiano, aye. Atkins? Atkins, aye. Bonilla? Hing? Hing, aye. Garrick? Garrick, no. Gordon? Hayashi? Hernandez? Hernandez, aye. Lowenthal? Lowenthal, aye. Mansour? Mansour, no. Mitchell? Mitchell, aye. Nastandi? Nastandi, no. Pan? No. Pan, no. Perez? Aye. Perez, aye. Silva? Silva, no. Smythe? Williams? Aye. Williams, aye. That's 9.
That has 9. Needs one more. It'll remain on call. Thank you, Ms. Butler.
Thank you.
Friends, now we're moving to item 29, AB 1360 by Mr. Swanson. Good evening, Mr. Swanson. Maybe I'll just preface this before you open. Members, there have been some extensive efforts made on amendments here. I think the author will address those, but let's hear the affirmative testimony and support. We'll hear opposition as standard, and then we can get more specific at that point. Thank you, Mr. Swanson.
Thank you, Mr. Chairman and members of the committee. I present AB 1360, which is a bill that has been a work in progress for about 3 years, and a lot of discussion. When this bill was heard in the Assembly Committee on Business and Professions and Consumer Protection, I committed to working with opposition on amendments to the bill. I've met with the California Medical Association and drafted proposed amendments to meet the concerns they raised in committee. The amendments, which are being passed around in mock-up form, limit the bill to hospitals owned and operated by the healthcare districts, limit the number of physicians to 5 per district hospital, limit participation in this pilot to district hospitals that provide a percentage of care to Medicare, Medi-Cal, and uninsured patients that exceed 50% of the patient's days, and requires that the medical staff and the elected trustees of the district hospital concur by affirmative vote on whether or not to hire a physician. In instances where the medical staff and the hospital board disagree, this bill allows for the hospital to request a non-binding mediation. I'm committed to working with the opposition to put in place frameworks for assessing community need and creating criteria for the medical staff's vote and elements that the original pilot program lacked, which allows for an opportunity to monitor whether it's working efficiently. These amendments represent a compromise between my office and the CMA that shows both sides understand that doing nothing is not an option. I also want to state that I am open to working with other opponents to ensure that there are not adverse impacts by this legislation should it pass out of this committee today. Research from the California Department of Health Care Services show that a number of Medi-Cal beneficiaries increased in every single county in the state between 2008 and 2009. The pending implementation of federal health care reform will only make this problem worse because it will increase the number of Medi-Cal recipients to more than 5 million. While AB 1360 is not the magic health care bullet to solve our problems, it is a modest step to address a growing health care crisis facing California with minimal cost to the state. We have also reached out and tried to and offered to receive amendments from the clinic community to address any concerns that they have. We still remain open to discussing that, but as the bill states, nothing in the bill. The bill prohibits the district hospitals from actively recruiting to employ physicians and surgeons employed by these federally qualified health centers, rural health centers, and other community clinics not affiliated with the district. And we are open to, as we've demonstrated so far, in considering language to address this problem. This is an attempt, Mr. Chairman and members of the committee, to make doctors available in rural areas and in inner city areas for an underserved population. That is it. And we're trying to we have to do this a step at a time. If the end result is that there's one physician that helps one child in need, then we've accomplished something very important. I would ask my witness to self-introduce.
Thank you. Witnesses in support.
Dean Garfila with the California Medical Association. We are support as amended on 1360. 1360 follows the direction of the Medical Board of California study on the original pilot program by expanding the amount of hospitals and the amount of physicians eligible to participate while retaining important patient, physician, community, and health clinic protections. I won't repeat the amendments that Mr. Swanson has presented, but I will add that per the amendments, the number of potential physicians to be hired in comparison to the original pilot program will go from 20 to approximately over 200. The amount of hospitals that will be able to participate in this program will grow from 20 to approximately over 40. And equally important, as Mr. Swanson mentioned, it retains the medical staff participation in the decision to hire a physician. That's very, very important to the CMA. Again, won't belabor the point, but the reason why we asked for that amendment is to ensure, again, that a hospital system, like so many other systems, in order to run effectively and to run efficiently, there needs to be the appropriate balance, checks and balances, and we believe with the medical staff participation, it does meet that important checks and balance. In addition, and I'll close, that because it's a pilot program, the amendments also allow for a comprehensive study to take a look on whether or not this pilot program does in fact effectively incentivize physicians to go into these district hospitals. I'll close there. I'm obviously here to answer any of your questions, and I respectfully ask for your aye vote.
Thank you. Other witnesses in support? Witnesses in opposition? Please come forward.
Good afternoon, members, Chair. Lori Johnson with the California Primary Care Association, representing over 800 nonprofit private community clinics and health centers. As of this morning, we are opposed unless amended. We submitted amendments to the author's office. The amendments would aim to protect our primary care providers by limiting the pilot to applying to only specialists. And those specialists that are not providing primary care services like pediatrics and family medicine. The bill, even as amended, is harmful to community clinics and health centers by essentially unleveling the playing field, which makes it completely difficult for us to retain and recruit primary care providers, and inevitably will affect access. We thank the author for his willingness to work with us, and we are hoping, if this bill does get out, that we can find some type of commitment. Thank you.
Jason Vega with the Central Valley Health Network. I do want to echo the thoughts of CPCA, our colleague at the state level, and also commending the chair and willing to continue to work with us. I want to echo the concerns as well. I would like to point out that Central Valley Health Network represents approximately 100 community health centers throughout the state of California. We do about 2.3 million patient visits. And I do agree with the author that if just one physician helps out one child, then it's worth it. And I also want to point out that just one physician, in general, in our healthcare centers, see anywhere from the number of 3,000 to 5,000 patient visits a year. So that being said, we have to understand that the impact of this is going to be very dramatic in rural areas as well. I would also like to point out that if we thought this bill actually created a lot more physicians coming to the state of California, we would be in agreement that how do we work this through? We don't believe that this bill creates any new physicians at this point. We believe at the very best it kind of shifts from where primary care physicians are currently working, which would be on a frontline basis within federally qualified health centers, to a hospital or an emergency room setting, which is obviously where community health centers are trying to keep the patients out. We have firsthand experience thus far in the Central Valley. It's very hard for a community health center to compete with a larger health system like a hospital system. One of our members actually just recently had lost a physician assistant, had lost a nurse practitioner, and within the last 2 months lost 2 providers to the same healthcare district. And once again, if you take a look at that, 2 providers could be anywhere between 6,000 to 10,000 patient visits inside one community. And in some communities, our community health centers actually play an extremely large role. For example, we have a community health center, a fairly qualified health center in Madera, where the population is approximately 55,000 people. But that community health center does 82,000 patient encounters a year. So we applaud the author for keeping the opportunity open to work with us. We're looking forward to continuing to work with them. I would like to point out that prior to this, we were actually in opposition. We stand with CPCA and echo their concerns, and we have moved to an opposed unless amended position at this point. Thank you.
Mr. Chairman and members, Barbara Glazer with the California Hospital Association. We didn't see the amendments until midday today. We don't have a formal position of opposed, but I wanted to put our concerns on the record. We are concerned specifically with the amendment that would require medical staff approval, and it would require it for each and every time the hospital were to hire a physician. We think a more appropriate level would be that you would have to get medical staff approval one time, and that would be to participate in the pilot. But to get it for each and every hire, we think is an inappropriate level. We think that's asking too much of the medical staff. It is not appropriate as their role, and for these reasons, we are concerned.
Thank you. Other witnesses in opposition?
Beth Capel, on behalf of AFSCME, we were previously the sponsors of this measure. We are, with these amendments, we are no longer in support. Thank you.
Thank you. Any other witnesses? Seeing none. Committee members, questions, comments?
Mr. Chairman, if I could just add that we are prepared to sort of go the extra mile to continue these discussions. And our hope would be that, for instance, the recent incident where their physicians have left, that actually we could figure out language that would, that would address that question.
Salute.
And so our hope is that we will continue to talk. We're open to do that. But we think that, as you have outlined, that the fact that that any parent would have to go 90 miles to get service is sort of unacceptable. And so we're open to continue discussion, Mr. Chairman.
Thank you. Ms. Mitchell.
I wanted to get a sense of what community clinics, what your amendments are. Is it your concern that you will lose physicians that will go over?
Correct.
And so what was your proposed language to fix that or prevent
Our
that?
proposed language was to limit the pilot to just specialists. So these would not be our primary care providers, as Jason Vega just spoke about, that are basically our bread and butter. These would be the specialists, and that they could still directly hire. So that is how we wanted to limit the pilot to protect.
And so fundamentally, doesn't that kind of change the overall scope of your intent, Mr. Swanson?
Well,
if your intent is
we just got the amendments this morning, so we would like to look at them, and we've said we're open to some discussions. I think that if we also talked about developing a criteria for the physicians, and if in the criteria it's very specific that you don't recruit from clinics and you don't rob clinics, which is part of the bill. If that's part of the review process, the review process should encompass that and other things, and we're still going to work on that language. And so I think there's some way to make it explicit that should not happen.
My concern would just be in that this is the deadline hearing. These are kind of substantive proposed amendments that are appropriate to be heard in the policy committee. So I just have that concern that we as a policy body won't have the opportunity to weigh in and actually hear the outcome of your compromise.
Thank you, Ms. Mitchell. Ms. Atkins?
Thank you, Mr. Chairman, and I do want to commend the author for working, obviously, at great lengths on trying to bring the parties together and to get some consensus on some key issues. I understand the need and the necessity for this bill. I do have, given that I work with so many of the community clinics in my own communities, I do have some concerns about the issues brought up by CPCA, and so I echo Ms. Mitchell's comments about kind of where we are in this process. So I just wanted to put that on the record.
Dr. Pan.
Yes, as a physician who's still practicing in a community health center, I do want to thank you, Mr. Johnson, for taking all the amendments that you have to date. And I did hear your commitment to work with. This is the last policy committee, so but certainly I hope that
from a medically underserved area, where currently the Eastern Coachella Valley we have one physician per 9,500 residents. Obviously, this is a major concern. Whether it's a physician that's providing primary care or whether it's a specialist. At the end of the day, both our rural hospitals and community clinics need both. And ultimately, our constituents need that access. I'm inclined to support this measure, Mr. Swanson, because I know ultimately at the end of the day the gravity of the issue coming from a community clinic model in which we always had to figure out ways as to how to compete with other geographic areas or for that matter even with hospitals that had more resources. However, I will state though that it is my hope, and you've already stated yourself and you're a man of your word, in which you're going to work with our community clinics to ensure that there is balance. And I would also say that out loud to our community clinics. There's got to be some balance here. And something's got to give. Sooner or later, we got to count our losses and our blessings and ultimately make a decision on behalf of the folks that we are representing. And although this may be a dilemma, ultimately my hope is that we come to some resolve so that we can truly support, provide the cultural competent, quality, accessible, affordable health care that our constituents need. So I'm going to ask that we continue to work on this measure. I'll support it today, but if there is no resolve in the future, I may not be able to support it on the floor.
Thank you, Mr. Perez. Just before you close, Mr. Swanson, if I might frame what has been a very interesting effort by your staff, committee staff, the stakeholders. First, I want to acknowledge your openness to working with stakeholders on this and your continued commitment to try to find how we thread this needle. I've been clear about my concerns of potential unintended consequences or maybe predictable consequences of impacts on community clinics. My view is that we all need to be clear that what motivates this bill is bringing more doctors to underserved areas. And I don't think there's any stakeholder here who disagrees with that objective. We want to get more services. With the Obama reform, we have an opportunity to increase eligibility and access. And there's some real questions as to whether we'll have the workforce capacity to meet that increased eligibility and growing need in our state. So again, your bill goes to trying to incentivize getting doctors into underserved areas. As was pointed out by the primary care and clinic representatives, one of the concerns is if a hospital has superior recruiting power based on an ability to offer better packages of compensation, that could work to recruit a potential doctor coming to a rural area to go to the hospital as opposed to the primary care clinic. One of the precepts of the Obama reform is patient-centered medical home, linguistically, culturally sensitized to the community to be served. The progress that's been made to date, I don't think we're quite there, but there have been some accommodations made to prohibit direct recruitment from clinics. I know there's been some accommodations to doctors as well in terms of recognizing the need for doctor input in hospital hiring. I think there's not yet agreement on a definition of whether or not you would exclude primary care physicians, but I know you've committed today to continue to work on that. So what I would like to recommend, ask you to address, is that the bill is presented today as amended, that those amendments be accepted by the author. I think they represent the forward progress that everyone's been working toward, that those amendments will not be fundamentally altered without consultation with me and our committee staff, and that we'll reserve the right to bring the bill back, and I'll reserve the right not to support it in the future if I think it doesn't get to the point of finding the balance that we seek. So with that said, I do want to thank you for your motivation and your leadership identifying the need to get more services to underserved areas. I remain committed to working with you on this. I'm going to let you close in a minute. Ms. Mitchell has a comment, and then we'll move to your close.
My comment really, I think, is more process, and you'll have to pardon me if it's the question of a naive freshman. But as a health committee member, I think it's my responsibility to weigh in and understand a fully cooked piece of legislation. And so, Mr. Chair, perhaps you could help me. When you say that you reserve the right to bring the bill back, what does that really mean, and at what point would that happen? So I understand.
Because this is the policy committee related to this bill, we can pull it back here at any time, and it may not be afforded further hearing at that point. In other words, that could be the end of the road for this bill. But that's not my intent. My intent, I reserve that option. My intent is to find the way that we achieve this objective of getting more services to underserved areas without the unintended consequences of pulling docs out of rural clinics or unfairly competing in the recruitment of those rural docs. Mr. Ng. Okay, I just want to be clear. It was asked by staff. The amendments that the authors accepted are the amendments in the mock-up that have been circulated. The amendment that was suggested by the Primary Care Association of limiting to primary care doctors only, that is not yet an amendment that's been accepted by the author. It's one, though, that we're going to continue to work on that definition of how we might refine that protection.
Absolutely.
Is that your understanding,
yes.
Mr. Swanson? Mr. Ng?
Yeah, really briefly, just a comment about the process. If you look at the analysis on the previous legislation, you will see the road to good intentions is paved with bills being held in committee, bills that are vetoed, and I just want to commend the author. I happen to be his roommate, not roommate yet, but his possibly cellmate, but actually seatmate on the floor. We've been in so many hearings today. We do feel like these are roommates pretty soon. But I do want to commend the author, and I know that a lot of members have said that, we might pull the bill back, reserving, the right to not vote for it on the floor, and that's our prerogative. But I also feel that, members, I think this is a really historic moment. I think we have the buy-in and the cooperation of groups that have really, really been far apart. I won't go so far as saying people have had their lives threatened for voting for or against the bill, but I do know that this has been a very, very emotional and acrimonious debate. As someone who has served in an emergency room for 3 years, one of the few members who've seen that, and to see the importance of having accessible, affordable, quality health care, I think this is an important debate. I think this is an important bill, and I think that on the merits of what you've done so far, have been extremely commendable, and I think that deserves to have this bill moved out of this committee.
Thank you.
Mr. Swanson, would you like to close?
Yes, Mr. Chairman and members of the committee. First of all, I accept the chairman's position here wholeheartedly, and I will tell you that this bill, in all of its forms over the last 3 years, in terms of this effort to try to get physicians in the medically underserved area, has taught me one important thing, and that is that there will not be a bill that clears this House and it makes its way to the governor's desk unless everyone at this table agrees. There has to be a way for us to agree on a vehicle to address this question. No doubt in my mind about that. And so that's why, the chairman's position is very fine. We plan to be extremely transparent about this. I have wonderful clinics in my district doing a fabulous job, serving many citizens that are the underserved community. And so my respect and value for clinics couldn't be any higher. But I think now I'm asking everyone to come to the table, very simply put, and let's agree. Let's put in the proper protections, but let's agree, because I believe that there is a flood of potential patients that are going to be coming out that are going to need care. And it's not at that time that I want us to respond to it. I want us to respond to it now. And so I hope that everyone at the table, those that are not at the table, that we can hopefully bring back to the table, that everyone will understand the mission here is to serve that child that is without a physician, and I ask for your aye vote.
Thank you. Do we have a motion? We need a motion. Is there a motion to do pass as amended and refer to appropriations?
So moved.
We have a motion. Is there a second? We have a motion and a second. Again, this is do pass as amended in the mock-up and subject to the conditions we discussed and the commitments of the author. Refer to appropriations. Ask the clerk to call the roll.
Monning?
Aye.
Monning, aye. Logue? Amiano? Atkins? Bonilla? Bonilla, aye. Ng?
Aye.
Ng, aye. Garrick? Gordon? Aye. Gordon, aye. Hayashi? Hernandez? Lowenthal? Mansour? Mitchell? Nastandi? Pan? Aye. Pan, aye. Perez? Aye. Perez, aye. Silva? Smythe? Williams? Aye. Williams, aye.
That bill has 7. It'll go on call. Thank you, Mr. Swanson.
Thank you, Mr. Chairman.
Okay, members, I believe that completes our non-member presentations. And we're going to next go to item 14 by Ms. Mitchell, AB 652. And that next in order would be Mr. Garrick with AB 1192, followed by Mr. Williams.
I don't think there's only one person not here, right?
Looks like about 6 to go, members.
I don't think he's going to get enough.
Thank you. A frog in my throat that won't go away.
Members, if we could have your attention to Ms. Mitchell. The floor is yours, Ms. Mitchell.
Thank you, Mr. Chair and members. I've introduced AB 652 on behalf of my home county of Los Angeles and their Board of Supervisors. AB 652 addresses a problem for counties which are not reimbursed for state-mandated medical and forensic evaluations for some children in the child welfare system. State regulations require an initial medical examination or health assessment within 30 days for all children who are newly placed in out-of-home care. However, the forensic exam must be done within 72 hours.
Change the sign here.
While counties are authorized by statute to refer the child who is suspected of abuse or neglect for a forensic medical examination, if the exam is deemed appropriate, counties or law enforcement agencies are mandated by the state to cause the child to undergo additional forensic examinations. Again, AB 652 will require health plans to reimburse counties and or medical providers for the cost of these mandated examinations. Members, although this bill speaks to the finances of providing these exams, it's really about much more. What are we talking about today is the well-being of some of the most vulnerable and underserved children in our society. Today with me is Gerardo Pinedo and Karen Bernstein from the LA County Department of Health Services to testify on behalf of the bill.
Thank you. First witness in support.
Good afternoon, Mr. Chair and members of the committee. Gerardo Pinedo, Director of Government Relations, Los Angeles County Department of Health Services. LA County is the proud sponsor of AB 652 by Assemblymember Holly Mitchell. LA County Health Services operates 6 medical hubs in partnership with the Department of Children and Family Services. These medical hubs are located in county facilities, and an additional hub is privately operated by Children's Hospital. We provide high-quality, coordinated medical care with children in the child welfare system who are at risk of health and mental health problems. The initial health assessment goes far beyond a typical well-child exam because of the type of care that the child requires and the amount of time that the physician spends with each child. The forensic medical evaluation is performed in a victim-sensitive manner to determine physical, sexual abuse, and or neglect. Examining physicians are highly specialized with extensive training and experience, qualifying as expert witnesses in court. These same providers are mandated to document extensively. And I brought with me today just a sampling of the many forms that our physicians must complete every single time to document the findings of these examinations, largely as mandated by the state of California. Let me share a couple of examples about our patients. First, we treated a 2-year-old toddler victim of abuse. He was diagnosed with numerous health problems, previously undetected. He required surgery, physical therapy, and treatment for developmental disabilities. Secondly, and although difficult to fathom, we've seen pregnant little girls as young as 10 years old in our system. And these are only 2 examples of the many heartbreaking cases that we see and treat at our medical hubs. There are countless more. Without medical hubs, vulnerable children would continue to suffer from undetected illnesses, and it is quite possible that their abusers would continue to suffer by these abusers who perpetrate these devastating crimes on children. While the bill speaks to reimbursement from health plans, it is really about a lot more. It is about enabling reimbursement for physicians who provide essential services to some of the most vulnerable children in our entire system. I strongly urge your aye vote. Thank you.
Thank you. Next witness.
Good afternoon, Chair and members of the committee. My name is Karen Bernstein, and I'm the Director of Special Programs for the Los Angeles County Department of Health Services. As the Assembly member stated, state regulations require initial medical examinations for all children removed from their home and newly placed in out-of-home care by a local child welfare agency. And if deemed necessary, a forensic evaluation also is performed to determine if the child is a victim of abuse or neglect. Most children who are placed in out-of-home care are automatically eligible for fee-for-service Medi-Cal, in which case the medical services would be covered. However, the child first must be disenrolled from any prior coverage, which often is protracted. The Department of Health Services is not reimbursed for the cost of medical care provided to children who have other types of health coverage, such as Medi-Cal managed care or healthy families, because the services provided by the medical hubs are deemed by the plans to be out of network without prior authorization. While DHS routinely requests authorization for reimbursement, the claims are generally denied by health plans, and the county incurs the costs for these state-mandated medical and forensic examinations. These costs should be covered in the capitated rate already provided to the health plans. AB 652 represents a balanced approach to reimburse counties for the medical services they are mandated to provide to the state's most vulnerable children. I also ask for your aye vote on AB 652.
Thank you. Now we'll move to other witnesses in support. Name and organizational affiliation, please.
Hi, thank you. Kathy Sunderling with the County Welfare Directors Association, also representing the California State Association of Counties. We have a support and concept position on the bill and really appreciate the author and the sponsor working with us to ensure that the bill has sufficient flexibility to benefit all counties. Things are done a little differently from county to county, but I do want to underscore the importance of those forensic exams, which must be done very quickly to capture the necessary evidence for criminal prosecution. We really appreciate the author bringing this bill forward.
Mr. Chairman, members, Randy Perry there and Reed and Associates on behalf of the California Children's Hospitals Association in support of the bill.
John Lovell on behalf of the California Police Chiefs Association and the California Narcotic Officers Association in strong support.
Thank you. Other witnesses in support? Witnesses in opposition, please come forward.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans. I promise this is the last bill you'll be seeing me on today. I think one of my counterparts will be here later. But we respectfully oppose AB 652 for several reasons. This does expand coverage, and then it requires plans to pay for an expanded range of services, including forensic evaluations, which are not currently covered in the employer market very broadly today. In addition, the bill removes a health plan's ability to effectively monitor the quality and cost of the services mandated by this bill. By number one, statutorily setting the reimbursement rate that plans must pay for the mandated services and at a level that is higher than the actual cost that has been estimated for these services and at a higher rate than Medi-Cal fee-for-service. As mentioned in the previous testimony, it removes prior authorization abilities, and it compels out-of-network coverage by allowing the county government to select the providers performing the services mandated by the bill. The bill does increase premiums in the commercial market and costs Medi-Cal and other programs millions of dollars. In addition, as I testified on an earlier bill, one of the data points that the federal government will be reviewing in establishing the essential health benefits is the level of employer benefits that are currently offered today. They'll be surveying employers on that issue. The essential benefits must be equal in scope to the benefits provided by a typical employer. As I stated, these are not services that are typically paid for by employers today. Therefore, this is a prime candidate to conflict with the guidance on the essential benefits that are pending at the federal level, and thus the state will likely incur cost. We oppose for those reasons. Thank you.
Thank you.
Hi, Dan Chick with HealthNet. We are also opposed to this bill. We cover about 2.1 million lives in California, of which about 1 million are in the state health programs. We are the commercial provider of Medi-Cal managed care in Los Angeles County. We oppose this bill for two primary reasons. You're establishing an out-of-network relationship and a reimbursement rate in statute of $250 for the initial health assessment and $750 for the forensics examination. As pointed out in the JBIRP analysis, we believe that these costs do not reflect the true cost of providing the service. In fact, in the JBIRP analysis, it states that in 2010, initial health assessments were reimbursed in the range of $40 to $60. So in two instances here, we're being required to contract with a non-contract provider to provide the services, and we're expected to pay what we expect to be an inflated rate for these services. I don't know of any other instance where I've ever seen in statute where we've actually codified a reimbursement rate for these kind of services. This is sort of unusual. So for these reasons, we are opposed.
Thank you. Other witnesses in opposition?
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies, also opposed.
Thank you. Any other witnesses in opposition? Seeing none, committee members, questions, comments? Dr. Pan?
Ms. Mitchell, thank you so much for bringing up this bill. Certainly I'm familiar with the importance of doing both the forensic and screening exam for children who enter foster care or other types of systems. I do have a question and a comment. I guess I'll start with the comment. I guess I am a little concerned as well about setting the rate actually in statute, at least maybe a regulatory process in terms of trying to determine, hey, it's great for me. I think, maybe I'll look for a job there. But I'm not sure that's really the perhaps the most flexible way of doing it. But the question I have actually regards the author's amendment regarding the qualifications of the people who could actually perform the evaluation. I know that the specialty of child abuse pediatrics is a very new one. In fact, I was involved in the approval of that specialty just a few years ago. So there's very few people who actually are board certified or in fellowship training. Perhaps the one area that gives a little bit of expansion in terms of the people who might be able to perform. So there are probably both pediatricians and potentially even some family physicians who may be able to do it, but may not necessarily meet this qualification. I guess further clarification would be the last part. Our child maltreatment expert who's qualified as an expert witness in the court of law. Can you just further elucidate whether that would expand it enough in a way that both be sure that we have a qualified person, but not necessarily mandate that someone had to go through necessarily formal training, since it didn't really exist for more than a few years, at least as a board certified, as an accredited training system?
Thank you, Dr. Pan, for your question. So let's address the fact that we've included the rates in statute, since that seems to be a bone of contention for several of you. First of all, the current language does allow for the plans and providers to negotiate a different rate than those stated, the $250 and the $750, and counties can opt out if they so choose. And so we would be willing to talk about language about removing the $250 and $750 if that pleases the committee. Secondly, with regard to the specific definition of who qualifies in order to conduct the forensic exams. Can you respond to that?
Sure. We do understand that the board certification for child abuse expert is new, so we did not want to restrict to that board certification. We do want to be certain that it is not too broad, so that anyone who really does not have that expertise could be performing that and get the reimbursement rate that we are putting in the bill. We do. So we want to come to a somewhere in between, and what we have listed right now is a number of different ways that people can receive that training. Most people in California are receiving training from, there's a child abuse center at UC San Diego that most people in California who are experts in that area are receiving training through that center and following the state guidelines. So we think that we have listed it broadly, but we are willing to work on language to really fine tune that.
I guess just quickly in response, I'd certainly be happy to try to work with you if any of my knowledge would be helpful, perhaps. And I realize, again, this is during this particular phase of time where we have the situation. Again, I'd be interested in examining what this court qualification would be, or perhaps maybe the county can play a role. After all, this is a hub that the county's doing, and hopefully the county's not just hiring someone off the street, but hiring qualified people. And at least if someone has a body of experience who comes in that merits them being able to perform these exams, that might, and the county judges that may be just appropriate at this time.
Any other questions from committee members? If I might just comment my observation on that, I know you have accepted amendments as developed with the committee staff, and we've been cautious in understanding that this is trying to create a reimbursement for out-of-network, and that the unique nature of the victim, of the patient being identified, we believe the amendment language does go to capture that type of professional and has the flexibility of people that have received training that would qualify for that. So my understanding is you're presenting the bill as amended.
Correct.
And would defer to you to close if there are no other questions or comments from committee members.
I would just remind the committee that, again, counties are authorized by statute to refer the child who is suspected of abuse for the forensic medical examination. And if the exam is deemed appropriate, counties or law enforcement agencies are mandated by the state to undergo the fuller forensic examination. And so, I appreciate the health plan representatives expressing their concern with regard to costs. We've heard that pretty consistently throughout the course of today's hearing. The question to all of us is, then who will pay for it in terms of critical forensic health examinations that we are requiring of these law enforcement and local government entities? And so with that, I ask for your aye vote.
Thank you. This is a do pass as amended and refer to appropriations. Is there a motion? We have a motion and a second. I ask the clerk to call the roll.
Monning?
Aye.
Monning, aye. Logue? Logue, no. Amiano? Aye. Amiano, aye. Atkins? Atkins, aye. Bonilla? Bonilla, aye. Eng? Eng, aye. Garrick? Garrick, no. Gordon? Aye. Gordon, aye. Hayashi? Aye. Hayashi, aye. Hernandez? Aye. Hernandez, aye. Lowenthal? Aye. Lowenthal, aye. Mansour? No. Mansour, no. Mitchell? Aye. Mitchell, aye. Nastandi? Aye. Nastandi, aye. Pan? Aye. Pan, aye. Perez? Aye. Perez, aye. Silva? No. Silva, no. Smythe? Williams? Aye. Williams, aye.
That has 14. The bill is out. As Mr. Garrick approaches the podium on AB 1192, we're on the home stretch. We have 5 bills remaining. We have a number on call, so I will ask members to stay close because we're going to go through the on-call bills in a systematic fashion on the record, and so do please stick with us. Item number 20, AB 1192. Mr. Garrick, the floor is yours.
Thank you, Mr. Chair and members. Appreciate the opportunity. Thank you. I am presenting AB 1192, a simple bill to raise awareness among new parents about the risk of pertussis, more commonly known as whooping cough. According to the pertussis report provided on the Department of Health website, as of March 9th of this year alone, there has been 514 reported cases of whooping cough. There have been 10 deaths, 9 were of infants 2 months of age or younger. Raising awareness of this disease or this problem, this health challenge, in new parents of the risk of pertussis for infants is a great first step. It is their choice to decide whether or not to get a vaccination, but they cannot make an educated decision if they don't have the information. Therefore, the department already produces a report on their website. The hospitals can print that report and put it in their discharge package for new parents. There is a minimal amount of work involved with a maximum output of protecting our most vulnerable California citizens, the newborn. At this point, I'd like to have Mary Griffin introduce herself and the two witnesses that are here today. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. My name is Mary Griffin, and I've been around for a while. I would like to introduce to you Andrew Resignati, Nato. Sorry about that, Andrew.
You got it.
And he is the director of San Francisco Immunization Coalition. He's also the chair of the Bay Area Pertussis Committee. And Andrew's going to speak first to the issue. And before I forget to say what I wanted to say, I'm sorry, but we were not able to put in an amendment to this bill, and so our apologies. And I understand what the problem is, so I'm not here to argue about that. And then once Andrew has a chance to discuss a little bit of that, then we'll turn it over to Sarah Michael with Sanofi Pasteur, one of the longstanding vaccine manufacturers in this country. So with that, we'll turn it over, and I'm going to ask Andrew to go ahead and give us some of his thoughts about where this is about.
Okay, it sounds like you're introducing two witnesses to give substantive testimony. Because we have two witnesses, 3 minutes each, I will allow them each to testify, but within the parameters of about 5 minutes remaining, so about 2.5 minutes each. Is that all right?
Yep.
Thank you.
Thank you, Mr. Chairman and committee members. The Bay Area Pertussis Task Force has been working with birthing hospitals in San Francisco and the Bay Area to inform family contacts with newborns and new parents about pertussis, Tdap, and hoping to immunize them and do what we call cocooning, which is provide immunization for all contacts of a newborn. We did have a baby die in 2005 in San Francisco. The baby contracted the disease from his mother. His mother actually coughed herself into contractions while she was at the hospital. She was sent home with her newborn, was not diagnosed with pertussis, gave the child whooping cough, and the child later died from whooping cough. I'm happy to say that all San Francisco hospitals now do inform families about pertussis, about vaccination, and offer the vaccine. But I know statewide, not all hospitals do this. I think this is a standard of care in order to protect babies. We mentioned that there's been 10 deaths. There were 10 deaths in 2010. We just had an epidemic of pertussis with over 9,000 cases, and we had 663 hospitalizations, most of them in infants. And that's a lot of disease that can be prevented. This bill is a good first start in informing parents. I do think the language of the bill can be stronger and require hospitals to inform parents. But I do think it's a step in the right direction of making sure families know that pertussis is a deadly disease and protecting the newborn.
Thank you very much. Next witness.
Okay. Thank you, Chairman Moaning and members of the committee. As Andrew said, pertussis, also known as whooping cough, is an acute infectious cough illness that remains significant in the U.S. and at epidemic levels in California, despite long-standing routine childhood vaccination. Regarding infant pertussis, research found that when the source of infection for pertussis in infants was identified, family members were responsible for spreading the disease to the baby up to 80% of the time. And more specifically, parents were the source up to 50% of the time. Because of the significant rise of pertussis in the U.S., the CDC's Advisory Committee on Immunization Practices has issued recommendations for the use of pertussis vaccine, stressing the importance of routinely vaccinating those in close contact with infants. AB 1192 creates a mechanism for informing parents about the risk of pertussis to their newborns and how that risk can be minimized through immunization of all close contacts of the infant. Though some hospitals in California currently have postpartum programs in place, a minimum standard is needed to ensure all parents in California are informed of the risk of pertussis to their newborn and are put in a position to make an informed choice. Specifically, AB 1192 requires hospitals prior to discharge inform all parents of newborns about the risk of pertussis to their child and other recommendation to immunize close contacts of newborns. The bill would not require the hospital to provide the immunization or pay for the vaccination. For these reasons, we commend Assemblymember Garrick and the committee for raising this important public health issue, and we ask for the committee's support to move this bill forward.
Thank you. Any other witnesses in support? Any witnesses in opposition? Committee members, questions or comments? Mr. Garrick, would you?
Yes, Mr. Chairman, thank you for the opportunity to present this bill. I know that the committee is dealing with, as you mentioned at the opening of this hearing, bills with mandates, and I look to you as the chairman for any guidance as to what direction you'd like this bill to go.
Thank you. And first, let me thank you for bringing this important issue and for the witnesses focusing on this. I think everyone in the committee is well aware of the crisis of the pertussis epidemic in the state of California that fortunately has, I think, been put in check. I think the recommendations in this bill would benefit from some further work from the supporters and committee staff. You and I had some conversation about this earlier. I think there's clearly value to education of parents of newborns. There's nothing currently that I'm aware of that acts as a barrier in existing law to hospitals providing this information to parents of newborns. So what I would like to recommend, and with the author's agreement to this, that perhaps you consider converting this to a 2-year bill, bring it back to committee in January, and that we use the intervening time to figure out a best practice related to the objective of this goal.
Appreciate the chairman's recommendation, and I will take it at that.
Thank you, Mr. Garrick, and I thank you, the witnesses, for presenting here today. Thank you for your work on this critical issue. Thank you. Now, members, we will move to item 22, AB 1245 by Mr. Williams.
Thank you, Mr. Chair. Members, I don't know if I have to light myself on fire or anything to wake everybody up. It's been a long day. But I do have the right folks if I light myself on fire as a sponsor, the firefighters. Thank you, Mr. Chair. So I just want to make sure that people understand that we have amended the bill at the suggestion of committee staff and in working with the committee staff. As written, it addresses an issue with respect to background checks for emergency medical responders. To that end, the policy considerations raised the committee analysis questions, the preemptive nature of the bill. Some people were a little bit worried about that. That said, the amendments I offer today attempt to narrowly focus the issue of differentiating between a course of instruction that is available to anyone versus a new category of EMS practitioners. Specifically, the proposed amendments enable EMSA to move forward with developing a specified EMR course, but prohibits EMRs from being added as another practitioner in the EMS system without coming to the legislature with some details. These amendments ensure that if EMRs are inclined to be allowed to participate in the EMS system, they need to come back to the legislature for guidance on how to best structure their scope of practice and certification process so that we are not having people operate at this level of need of expertise without background checks or other things.
Thank you, Mr. Williams. Witnesses in support?
Mr. Chair, members of the committee, Christy Bauma, representing the California Professional Firefighters. The author described it well. We are satisfied that the committee has provided some tremendous advice, that these decisions in the purview of the legislature, and this bill makes clear that they will come back to you should the need arise.
Thank you very much. Any other witnesses in support? Any witnesses in opposition? Seeing none, committee members, questions, comments, motions? We have a motion and a second. Seeing no questions from the committee, Mr. Williams, I want to thank you and your staff and the sponsors for working with our staff to this noble objective. Would you like to close?
Just thank you for your time.
Thank you, and I assume you're encouraging an aye vote. Is that a safe assumption?
But I think I've worn you guys down anyway.
Thank you. Okay, there's a motion and a second. This is due pass as amended and refer to appropriations. Clerk will call the roll.
Monning.
Aye.
Monning, aye. Logue. Aye. Logue, aye. Amiano. Amiano, aye. Atkins. Atkins, aye. Bonilla. Bonilla, aye. Ing. Ing, aye. Garrick? Aye. Garrick, aye. Gordon? Aye. Gordon, aye. Hayashi? Hayashi, aye. Hernandez? Aye. Hernandez, aye. Lowenthal? Aye. Lowenthal, aye. Mansour? Mansour, aye. Mitchell? Mitchell, aye. Nastandi? Pan? Pan, aye. Perez? Perez, aye. Silva? Silva, aye. Smythe? Williams?
Aye.
Williams, aye. Has 17.
That bill has 17. I think a record for today. Congratulations. That bill is out.
Chair members.
We'll now move to Ms. Bonilla, item 23, AB 1296.
Thank you so much, Mr. Chair and members. First, I would like to thank the chair and the committee staff for their help on this measure. I'm happy to take as authors amendments the amendments suggested in the analysis. AB 1296 complements, I should at least explain what it is, Affordable Care Act legislation. One name for this is No Wrong Door, or One Open Door to Health Care. And the Affordable Health Care Act provides 100% federal money from the exchange to put these systems into place. And what we're concerned with here is making sure that no matter where a person applies, they would be accepted and directed correctly. I will abbreviate my comments, and I have with me Elizabeth Landsberg from the Western Center on Law and Poverty, a sponsor of this measure, and ask her to go ahead and testify. Thank you.
Thank you.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, pleased to sponsor this bill to streamline the way consumers get into public health coverage. As the Assemblywoman stated, this is the No Wrong Door bill. Today, the onus is on the consumer to figure out where to apply under the bill. The application will be for Medi-Cal, Healthy Families, and the new exchange. We have to have a system up and running and tested by June of 2013, so this legislation is urgently needed. There is federal funding for it, and we urge your aye vote. Thank you.
Thank you. Next witness in support.
Kathleen Hamilton with the Children's Partnership. We're pleased to join our colleagues here in supporting this legislation. As you know, California has more than 7 million uninsured people, and over 1 million of those are children. So the intention of this bill is to implement the provisions of the Affordable Care Act that require this no wrong door, simplified, modernized enrollment, retention, renewal system that'll enable more of our families and children to get enrolled in the right program, stay enrolled if that's where they belong, and thereby get the health coverage that will serve them so well. So we're happy to support the bill.
Thank you. Other witnesses in support? Name and organization, please.
Beth Capel on behalf of Health Access California, CPEN, and AFSCME in support.
Judy Wolin with NAMI California in support.
Julia DeVos with the Urban Counties Caucus. We're part of a larger coalition which has a support and concept position on the bill. I'm also here on behalf of the California State Association of Counties and the County Welfare Directors Association. We appreciate the author, the sponsor, working with us on our issues, and we hope to continue to work with them as the bill moves forward. Thank you.
Stephanie Hodson with United Ways of California, also this afternoon on behalf of the 100% campaign, as well as the California Children's Health Initiatives, all in support of this bill.
Thank you. Any other witnesses in support? Witnesses in opposition? Seeing none, we have a motion and a second. Would you like to close, Ms. Bonilla?
I would just say that we need a user-friendly, efficient system that works for real people, and I would respectfully ask for your aye vote.
Thank you. This is due pass as amended and refer to appropriations. Clerk will call the roll.
Monning?
Aye.
Monning, aye. Logue? No. Logue, no. Amiano? Aye. Amiano, aye. Atkins? Atkins, aye. Bonilla? Aye. Bonilla, aye. Ing? Ing, aye. Garrick? No. Garrick, no. Gordon? Aye. Gordon, aye. Hayashi? Hayashi, aye. Hernandez? Aye. Hernandez, aye. Lowenthal? Aye. Lowenthal, aye. Mansour? No. Mansour, no. Mitchell? Aye. Mitchell, aye. Nastandi? Pan? Aye. Pan, aye. Perez? Aye. Perez, aye. Silva? Silva, no. Smythe? No. Smythe, no. Williams? Aye. Williams, aye. I think Doss beat me.
That bill has 13. The bill is out. Members, I'm going to turn the gavel over to Vice Chair Logue. I'll be presenting two bills. I would urge members who aren't present to maybe make your way down to 4202 because we will be removing bills from call after I present the next two bills. Thank you, Mr. Logue.
'62. Mr. Monning, AB 62.
Yes, thank you.
Move the bill.
Thank you, Chair and members.
2 years.
AB 62 is a technical clarification to the provisions that implemented the Medi-Cal Section 1115 waiver. SB 208, authored by Senator Steinberg, authorized a pilot project to coordinate medical services provided to persons who are duly eligible for Medi-Cal and Medicare. I'll spare you further details and remind you that AB 62 also ensures that the stakeholder process that is being used for the waiver includes these pilot projects. I don't have witnesses to present, but I can answer any questions that the committee might have. I urge your aye vote.
Thank you. Any witnesses in opposition? No witnesses in opposition. Members? No members? Closing?
I would ask for your aye vote. Thank you.
Excuse me. Do pass and refer to appropriations. Roll call.
Monning?
Aye.
Monning, aye. Logue?
Aye.
Logue, aye. Amiano? Amiano, aye. Atkins? Atkins, aye. Bonilla? Bonilla, aye. Ing? Ing, aye. Garrick? Garrick, aye. Gordon? Gordon, aye. Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Lowenthal? Lowenthal, aye. Mansour? Mansour, aye. Mitchell?
Aye.
Mitchell, aye. Nastandi? Pan? Pan, aye. Perez? Perez, aye. Silva? Silva, aye. Smythe? Smythe, aye. Williams? Williams, aye. It's 18. It's 18.
18 is out. Thank you.
Thank you very much.
18. Means you buy dinner again.
That's what you get when you're chair.
Prerogative of the chair. Privilege of the chair.
AB, excuse me, AB 1083.
Move the bill.
Thank you. AB 1083.
Opposed to it, you know.
Thank you, Mr. Chair and members. Again, I will be brief on this. Let me just take this moment to thank committee members for your patience and perseverance this afternoon and for sticking with us. I think we've made good progress this afternoon. On AB 1083, this amends California law regarding small employer coverage known as small group coverage. I'm accepting as authors' amendments the amendments described in the analysis. Most of these are either technical or reflect drafting errors. I am also removing the wellness program provisions from this bill. Like several dozen other states, California reformed its small group law in the mid-1990s to require guaranteed issue, guaranteed renewability, and to limit rating based on health status to plus or minus 10%. In 2014, federal health reform requires us to make further changes, eliminating any rating based on health status and changing the size of employers that are covered. My bill generally conforms California law to the new federal reform law. I think I'll just conclude by reminding you that 3.4 million people in California purchase health insurance in the small group market. Millions more could gain access to coverage either through the exchange or in the private small group market. This bill is intended to conform California's laws to the federal law while maintaining protections that are stronger than the federal law. I ask for your aye vote and have witnesses here to provide support for the bill. Thank you.
First witness, please.
Good evening. Thank you for giving me the opportunity to meet with you today. My name is Virginia Donahue. My husband and I own Pet Camp. We have 2 locations in San Francisco where we provide overnight and day care for dogs and cats and health care for 15 employees. We have provided health care since 2000 because we believe access to affordable health care is a basic human right. That said, we have seen a painful escalation in costs. The coverage we provided in 2000 cost us $30,000 a year. To provide that same level of coverage today would cost $180,000. Currently, together with our employees, we spend a backbreaking $90,000 a year on health insurance. As costs have spiraled out of control, the quality of care we have been able to provide has declined. We have limited our costs in several ways. First, we only pay for coverage for our employees, not their families. We simply can't afford it. Sadly, that limits our attractiveness as an employer and hurts our employees. Second, we have switched from a plan with a low copay to one with the highest copay on the market. Third, while we used to pay 100% of the premiums, we now pay only 90%. Now, here's the cost we didn't reduce. We didn't get rid of our employees who are over 40 years old. When you are a small employer, you are charged based on the insurance carrier you use, the type of plan you have, and the age band that each individual employee is in. My employees who are under 30 years old cost about $260 a month. My employees over 60 years of age cost more than $1,000 a month. I have 3 employees who are 60 or older. Fortunately for me, 2 of those 3 get their health coverage elsewhere. My remaining employee, who is 60, costs me $9,000 more per year than his younger counterpart who does the same job. I bear this cost because he's been with me a long time. I know him and I've experienced what he brings to the table. But for many jobs, it would simply not be economically rational to do this. As a society, I don't think we want small employers shedding older workers because their health care costs are so much higher. And if I were motivated solely by finances, that is exactly what I would do. The bill before you today, AB 1083, would help fix this problem by placing limits on how much more older employees can be charged. From my perspective, the system that exists now is unsustainable. If you are a small business navigating the world of health insurance, you are a canary in the coal mine telling the rest of the country that the health care system is broke and must change before it is too late. Thank you.
Beth Capel on behalf of Health Access California. We're pleased to co-sponsor this measure along with Small Business Majority. I don't think I can top the eloquence of that testimony. I will just offer to answer any questions and say that one of the things this bill does is say that for the oldest employees their rates can't be more than 3 times as much as the 20-year-old. So that will help with workforces with older employees. And with that, I'll ask for an aye vote. Thank you.
Thank you. Other witnesses in support, your name, organization, position, please.
Austin Price on behalf of the California Public Interest Research Group and its members around the state, and we're also in support of this bill.
Any other witnesses in opposition? Please come forward. Please make room for them. Go ahead.
Yes, Mr. Chairman, Mr. Vice Chair, John Lovell from the California Association of Health Underwriters. First of all, we want to thank the author and the sponsors for the time they've afforded us to meet with them and discuss the issues with the bill. And the objective of the bill is laudable. There's a number of very good things in it. But we are extremely concerned about the so-called anti-steering provisions of the bill. We believe that the unintended consequence of those provisions will be precisely what the bill is trying to avoid. We believe that it will that it will create incentives for carriers to leave the exchange. We believe that it runs the risk of, again, unintentionally, of making the exchange the repository of bad risk. We have worked in the last day in developing some proposed amendments that we haven't yet shared with the author. We will if the bill moves out of this committee, because we believe that our amendments will treat with the issues of steering without creating the problems that the bill currently has. We just literally developed these amendments before the hearing today. That's why, I mean, it's not like we're trying to keep this from anybody, but we got them finalized by about 1:30 today.
Next witness.
Charles Bakke with the California Association of Health Plans, here on the night shift for my colleague. I'm not going to repeat everything he said all day today, other than the fact that we should use great caution in passing state laws intended to implement federal health care reform. We're reviewing the author's amendments. We appreciate the work of his staff and the sponsors in trying to help us navigate what is a very complicated set of amendments to current law. We still think there might be a couple of areas that still stray from strict conformity, but we're looking at those, and we'll get back to the author and his staff. There's still two key issues that are just worth mentioning, riffing off the comments of Mr. Lovell. Section 2 of the bill, we absolutely understand the intent is to mitigate adverse risk selection for the California Health Benefits Exchange and prevent the steering of high-risk individuals into the exchange and healthy risk individuals outside the exchange. We've spoken with the sponsors of the bill and expressed concern that the way the bill is currently crafted, it puts the responsibility on health plans to solve that problem. And since we don't know how the Health Benefits Exchange is going to structure commissions for brokers and agents, we really have a lot of unknowns about that provision of the bill. And then finally, we would just caution that the bill does put many provisions of federal law into state law next year. Many of those provisions are dependent on the success of the individual mandate at the federal level. And that individual mandate, as many of you members know, is currently under litigation at the Federal Appeals Court level and potentially could go to the U.S. Supreme Court if California moves forward by placing guarantee issue in its statutes. We may have to revisit that in the future if that individual mandate fails at the federal level. Obviously, the author can't solve that problem. It's just worth noting to the members. Thank you very much for all your hard work today, and good night.
Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies, also opposed.
Any others in opposition? If not, questions from committee members? Closing statements?
Thank you, members. Mr. Chair, members respectfully urge your aye vote on the bill as amended, the amendments that you have in your analysis. Thank you. And I just say the night is young.
Okay, there is a motion and a second. Do pass and refer to appropriations as amended. Roll call.
Monning?
Aye.
Monning, aye. Logue?
No.
Logue, no. Amiano? Aye. Amiano, aye. Atkins? Aye. Atkins, aye. Bonilla? Aye. Bonilla, aye. Eng? Eng, aye. Garrick? No. Garrick, no. Gordon? Aye. Gordon, aye. Hayashi? Hayashi, aye. Hernandez? Aye. Hernandez, aye. Lowenthal? Aye. Lowenthal, aye. Mansour? No. Mansour, no. Mitchell? Mitchell, aye. Nastandi? Nastandi, no. Pan? Aye. Pan, aye. Perez? Aye. Perez, aye. Silva? No. Silva, no. Smythe? No. Smythe, no. Williams? Aye. Williams, aye. That's 13.
Measure passes 13.
Thank you. Thank you, Mr. Vice Chair, for your stewardship, and members for your patience once again. We have a number of bills on call. I'm going to ask the clerk to proceed in bill order, and we will lift the call, and she will call roll of absent members. We're going to move first to item number 2, AB 72 by Mr. Eng. Clerk will call the roll of absent members.
Logue?
No.
Logue, no. Bonilla? Yes. Bonilla, aye. Hayashi? Aye. Hayashi, aye. Hernandez? Lowenthal? Aye. Lowenthal, aye. Mansour? No. Mansour, no. Mitchell? Hernandez, aye. Mitchell, aye. Nastandi?
That has 13. The bill is out. Members, we have a number to go through. If you could really pay attention, not talk to each other, then when they call your name, we won't have to repeat the bill that we're going through on. That's not directed at anybody. That's a prospective comment. Okay, friends. Let's hold hands and get through this. Item 5. This is AB 215 by Mr. Bell. AB 215, Bell. Clerk will call the roll. Absent members.
Gordon. Gordon, I. Hayashi. Hayashi, I. Hernandez. Hernandez, I. Lowenthal. Lowenthal, I. Perez. Perez, I. Smythe. Smythe, no. Williams. Williams, I. 13.
That bill has 13. The bill is out. We move now to item 7, AB 310 by Ms. Ma. Clerk will call the roll. Absent members.
Logue.
No.
Logue, no. Bonilla. Bonilla, I. Gordon. Gordon, I. Hayashi. Hayashi, I. Hernandez. Hernandez, I. Mansour.
No.
Mansour, no. Smythe.
No.
Smythe, no. It's 12.
That has 12. The bill is out. We move to item 11, AB 428 by Mr. Portantino. AB 428. Clerk will call the roll.
Ing. Ing, I. Hayashi. Hayashi, I. Hernandez. Hernandez, I. Mitchell. Mitchell, I. Perez. Perez, I. Smythe. Smythe, no. 13.
That bill has 13. The bill is out. We move to item 12, AB 491. Mr. Portantino. Clerk will call the roll.
Atkins. Atkins, I. Ing. Ing, I. Gordon.
No.
Gordon, no. Hayashi. Hernandez. Hernandez, I. Lowenthal. Lowenthal, I. Mitchell. Mitchell, I. Smythe. Smythe, I. Hayashi, I. 16.
That has 16. The bill is out. We move to item 18, AB 1000 by Mr. Perea. Item 18, AB 1000. Perea. Clerk will call the roll.
Logue.
No.
Logue, no. Bonilla.
Item 18, AB 1000.
Bonilla, I. Garrick. Gordon. Gordon, I. Hayashi. Hayashi, I. Hernandez. Hernandez, I. Lowenthal. Lowenthal, I. Perez. Perez, I. Smythe.
That bill has 13. The bill is out. Item 24, AB 1300, Mr. Blumenfield. Clerk will call the roll.
Ing. Ing, I. Garrick.
No.
Garrick, no. Hayashi. Hayashi, I. Hernandez. Hernandez, I. Mitchell. Mitchell, I. Nastandi. Nastandi, no. Smythe. Smythe, no. Has 11. 11.
That bill has 11. The bill is out. We move to item 25, AB 1306 by Mr. Donnelly. Clerk will call the roll.
Hayashi. Hayashi, no. Hernandez. Hernandez, no. Mansour. Mansour, I. Williams. Williams, no. Has 6.
That bill has 6. It fails. Thank you. Moving to item 26, AB 1319 by Ms. Butler. Clerk will call the roll.
Logue.
No.
Logue, no. Bonilla. Bonilla, I. Gordon. Gordon, I. Hayashi. Hayashi, I. Smythe. Smythe, no. 12.
That has 12. The bill is out. Item 27, AB 1327 by Mr. Portantino. Clerk will call the roll.
Logue?
No.
Logue, no. Ing? Ing, aye. Gordon? Hayashi? Hayashi, aye. Hernandez? Lowenthal? Lowenthal, aye. Smythe?
No.
Smythe, no. Williams? Williams, aye. That's 11.
That bill has 11. The bill is out. We move now to item 29, AB 1360 by Mr. Swanson. Clerk will call the roll on absent votes.
Garrick? Hayashi? Hayashi, no. Nastandi? Nastandi, aye. Smythe? It's 8.
That bill has 8. It is too short.
Logue? Logue, aye. Silva?
I'm going to ask for reconsideration on Mr. Swanson's behalf. Hearing no objection.
9 to 1.
The bill has 9 votes. It's short a vote, and committee will grant reconsideration. Moving to item 31, AB 88. This is Mr. Huffman. This is being heard on reconsideration. Clerk will call the roll.
Logue?
No.
Logue, no. Amiano? Aye. Amiano, aye. Garrick? Garrick, no. Hayashi? Aye. Hayashi, aye. Hernandez? Mitchell? Aye. Mitchell, aye. Perez? Aye. Perez, aye. Silva? No. Silva, no. Smythe? No. Smythe, no. That's 10.
That bill has 10. The bill is out. That reflects the bills that were on call, members. Now, just before we adjourn, I know some of you are going to want to add on. I would ask that you approach the clerk in an orderly fashion, and we're going to go through a bill order. Committee is adjourned. We will continue with add-ons.